Weissman book and the Wilfley IPT for Group book. So you can just flip through them and sort of get a sense of what they look like and if they might be useful to you. So that's kind of going around as we talk. So here's the agenda for today. In brief, we'll sort of stick to it again like yesterday, maybe add a few more breaks in and things as we need to. But let's go ahead and get started. So first, what I wanted to do is use this video. I promised just a very brief description of how IPT and attachment goes together. So I honestly could not do it better than Dr. Simon, so I'm going to let him.
To assess during the initial phases of IPT. That's a checklist of questions to ask, and especially rather than having my face in a book, reading off a list of questions, it's much more important to let her tell the story. You get a lot more information that way as well. IPT is theoretically grounded in attachment theory, and that's a very important thing to assess during the initial phases of IPT. John Bowlby talked about attachment. There are several different models. One of the ones that I found particularly useful is this one by Bartholomew and Horowitz, which has 4 different attachment styles. Bowlby talked about internal working models, and those literally are ideas, concepts, constructs about oneself, and also about what relationships are like with other people. So over time, based on real-life experiences, people develop ideas or concepts, constructs about themselves as being either competent or not during crises, and then whether other people are likely to respond by helping during crises or not. So securely attached individuals would have a working model of self that they are pretty competent to deal with most crises, and a belief that they're not competent or a crisis is too great that they can rely on other people and that other people will step in and help. Those who are more preoccupied don't have that sense of security themselves and tend to rely very much on other people for the support that they need. Those that are more dismissive tend to push other people away and be more self-reliant. And then those people who are fearful don't have a strong sense that they can deal with crises or that others will be helpful either. Attachment can be evaluated during the initial sessions by using 4 different sources of information. The first one is the patient's description. Literally, how would they describe themselves? Not by asking, what do you think your attachment style is, but by asking, how would you describe yourself? What's your personality like? What do you like in relationships? What's it like when relationships end? How do you see yourself around other people? And most people can give a pretty good description of that. If you have access to somebody else, you can ask them about the patient as well, and they can usually give you good information to help assess attachment style. The therapeutic relationship is another way. So your reactions to the patient are informative about what attachment style is like. That's where transference comes into play. It's not directly addressed, but your experience of the patient is a very important way of thinking about what their attachment style is like. And then lastly, the quality of the patient's narrative is another way of assessing attachment. The better, the more well-rounded, the more three-dimensional the narrative or story the patient tells, the more likely they are to be secure. So direct inquiry, asking the patient during the interpersonal inventory about what relationships are like, is a great way to begin assessing attachment. And so is telling stories. And so asking a question during the interpersonal inventory about a story, or having the patient tell you a story, is another way to get information about attachment. And attachment's important in IPT because it's the template on which they build relationships. It influences strongly the way that they connect with other people, their clinginess or desire to have close relationship, or their desire to push other people away. It influences heavily the degree they're able to ask for support, and especially the degree to which they're able to ask for support in a way that others can respond to. It dictates the extent of their social support network as well, and also influences pretty strongly the way you'll need to adapt your style in relating to them during the course of therapy. So that securely attached people usually have a very strong social support network. They can ask for help in a way that's effective. And those that are less secure have more difficulty with that, and as a result, have more difficulty in resolving the crisis they're faced with.
access the patients?
I did not put them in there. If you, I put my email address in here. If you want to email me after this, then I can send that to you. Horowitz? Sorry guys, I'm having a hard time making it come back to my laptop. Oh, apparently if you push the button 3 times the same way, it works. Okay. So let's start by just going through a brief review of the large amounts of information that we talked about yesterday. I know it was a lot, so I hope it's marinated overnight a little bit and you've been thinking about it, and I'm happy to talk about any questions that came up for you as you were thinking about it. So the basic concepts of IPT are that there's a goal to reduce symptoms by improving social or interpersonal functioning. And we focus on the present, on the here and now, the current functioning in these relationships. And we have problem areas, 4, potentially 5, that are defined very early in treatment. And there is a treatment structure that dictates the flow of the sessions, but it's not rigid. So you should feel free to be a little flexible depending on what the patient in front of you needs and how your clinical style is. And then the therapeutic stance, what is the role of the therapist, is active, engaged, warm, encouraging, and directive. So that is sort of the basic nutshell. What we know about the treatment structure is that it's typically 16 to 20 sessions, although there are brief versions, as I mentioned, and one of the manuals going around is a brief version. And it includes these 3 phases: the initial, the intermediate, and the conclusion or termination phase, and then the optional maintenance phase as well. And the initial phase is dedicated to identifying the problem area that will be the target of treatment, usually 1, sometimes 2. The intermediate phase is devoted to working on the target problem area that you have developed in collaboration with your patient. And the termination phase then is devoted to consolidating gains made during the treatment and preparing the patient for future work on his or her own after treatment has ended. When needed, continuation or maintenance treatment requires a separate contract or discussion about what the goals are for the next phase of treatment. As a reminder, the tools for that initial phase, so your toolkit, are providing the diagnosis, the sick role. And we talked about the point of the sick role, that it's really about giving the patient information on there is a medical condition here, there is a treatment for it, alleviating some of the blame that patients might experience, self-blame that they might experience, and guilt. Provide a lot of psychoeducation, so really giving the patient information about what the diagnosis is, about the treatment itself, that it's evidence-based, and really helping the patient understand what you're going to do. You go through a brief treatment outline and contract for the treatment. You conduct interpersonal inventory, which often includes a timeline and a closeness circle. You've seen both of those. And then you identify collaboratively with the patient the problem areas. All of that put together is your case formulation. So when you talk to the patient, you saw in the video the biopsychosocial. I don't always have the patient write it out. I talk about it, but you could certainly use the method of having the patient write them out as well, depending on your style. The point is to give the patient this whole person perspective. The way we would think about a client is transparent. So you help the patient start to think about his or her own experience from that multidimensional point of view. The number of patients that feel relieved thinking about the biological factors that are contributing to what's going on with them is pretty remarkable. I mean, people don't typically think about themselves that way. That's how we're trained to think about people. And so it's really helpful to be transparent about that. And I find that later down the road, if patients start to learn to think about their experience more multidimensional, then it actually, clinically, anecdotally, I think it helps later on. So if you have a resurgence of depressive episode, and then they're like, oh, wait, you know, I just flew back from Africa and I've been sleep deprived for the last 3 weeks, and I've been eating, you know, nothing but rice because I didn't know what the food was there. And so suddenly patients start to understand the contributing factors to their own issues in a different way too. So you're sort of teaching them.
I was going to ask you, what are the biological factors? Obviously, if we're sleep deprived or we're not eating well, are those the only ones that?
I mean, other people, please chime in. So I talk to patients about neurotransmitters. If you have the education around that and that's in your vocabulary, I absolutely talk to them, especially if they're being treated with an SSRI or something. I explain the mechanism. You'd be amazed how many people prescribe medications without ever explaining what it does or the point. If a patient's on Wellbutrin, I talk about the difference between Wellbutrin in terms of SSRI mechanism of action versus Lexapro or something. So that I'll talk about sleep I talk about sleep with every single one of my clients sitting in front of me, every single one, because we know the impact of sleep disturbance on hormones and things, especially related to appetite and satiation signals. So if you're talking about binge eating, definitely do some homework and educate yourself around what are the biological mechanisms that can drive that from a hormonal perspective, and then look at how much sleep is influencing that.
So when they binge eat, it does sort of change the chemistry a little bit?
Yes, in a nutshell, but I think from a sleep perspective, we want to really think about the various hormones that are implicated when people sleep affected. It makes a real difference.
Yeah.
So that, obviously, in the case of someone who's breastfeeding or something, I would talk about that. I would talk about amount of exercise that the person gets or doesn't get. I would talk about pain. If they're in chronic pain, that's certainly a factor. If they have medications on board that are related to blood pressure or cholesterol or other things, I might mention those. And then get from the patient what they think. Any other thoughts about? Yeah.
When I think about the season and how much fresh air and outside.
Yes, definitely. And vitamin D. I mean, people's vitamin D is in the toilet a lot of times. And so I always am saying, have you had your vitamin D checked lately? Are you up to date on your regular blood work? If someone's post-bariatric surgery, that's a really important thing to pay attention to, because the vitamin deficiency can really impact people's functioning. And sometimes people who have had bariatric, especially many years ago, sort of forget the importance of taking their multivitamin supplement, and it's really important. So if they have a medical condition, a diagnosis of something, or renal disease or diabetes, I would talk about that. So there's lots of biological factors. So tools for the intermediate phase are the use of the therapeutic relationship, encouraging the patient to experience and describe their affect, so the acceptance of painful affect, learning to use affect in relationships, clarification of affect, so do the patient's facial expressions and experience in the room match the words that they're saying? Does the patient express affect in the therapy room or not? Noticing and addressing avoidance if that's happening. So it's not uncommon for a patient who comes with a really big interpersonal issue that's very obvious from the outside to want to talk around that issue a lot, understandably. So sort of gently reminding them that they're here to address the important interpersonal triggers that are going on. The tools you use a lot are communication analysis and role plays, and decision analysis, helping a patient think through maybe this, maybe that, the soccer game versus the New York trip, that's an example of that. And then making connections, continuing to link the interpersonal relationships and problem area to the symptoms, and continuing to link the symptoms to the interpersonal problems, and then improvements in the symptoms to improvements in personal relationships, and so forth. So I'd like to show you about a 12-minute role play. So this is, remember the girl that Dr. Young is talking about, the soccer game thing. So this is an example of the role play of how she would have that conversation with her dad, okay?
Okay, so it sounds as if you've got sort of two things you want to talk to him about. One is acknowledging that it's been difficult for you and that you recognize that you haven't been so easy to be around. But also helping him to understand.
That's because I forgot to do my job. Better?
That the comments that he makes, in fact, make it worse for you and make you more likely to sort of withdraw or respond to him in an angry way. Is that, did I capture it? Okay. I wonder also, you know, we've talked also about wanting to spend more time with him and really having some time one-on-one that doesn't involve Sue, it doesn't involve the boys, and in some ways at this point doesn't even involve your sister, because you want to be able to reconnect a little bit with him. And it sounds like that's scary, and that's one of the reasons why we need to figure out sort of a safe way of doing that. But that is another goal, is to try to improve your relationship with him and spend more time with him, but him understanding that there are certain things that he says or does that makes that very difficult for you to follow through. Is that right? Okay, so it sounds like it's sort of three different messages.
Yeah.
Does that make sense?
Yep.
Okay, so thinking about sort of those goals, can you think of a way that you might start the conversation with your dad next week? And before you do that, just to give you a sense of the session, you know, I'm going to be there, and we'll have a chance to sort of practice again right before he comes in. But I'll probably provide some introduction to him about why he's here. And then I'm going to turn it over to you. So that's sort of the context.
Okay.
And I'm going to be here, so you don't have to be nervous, because I'm going to be here to coach you. Okay?
Okay.
So if you think about sort of what you'd like to, how you might like to start the conversation with your dad.
Maybe I could say like, hey Dad, maybe you're here because I want to tell you.
Assuming there's a Wi-Fi issue. Arbitrarily disconnected from Wi-Fi, so. Yes, and experiencing interruptions.
To make those comments anymore.
Okay. And how do you think he might respond if that's sort of how you start out?
Maybe he would be like, what comments?
Right. So you wouldn't know what you were talking about.
Maybe.
Is there any other way you think he might respond if you said that?
I guess if I said that to him, he might get defensive.
Yeah, that's what I was thinking, that sort of, like particularly he may be a little nervous coming in, he's never been here with me before. And if someone said that to me, I'd sort of get my boxing gloves on and be ready to sort of fight a little bit more. So I know that that's something you do want to communicate, but I'm not sure that that's an ideal way to start.
Okay. Maybe I should just try to say something positive, like thanks for coming here.
Okay. And what do you think he might say if you said that?
You might say, you're welcome.
I mean, I think that's a nice way to start. And so if he says you're welcome, what might you say next? kind of thinking again about your goals for the
Well,
conversation.
He might be wondering why he's here.
Mhm.
So then I guess I could tell him that I want to improve the way things have been between us.
Okay, I think that sounds good too. So just putting it together, sort of thanking him for coming, and then saying, you know, I'd really like to improve how things are going between us. Can you think of sort of a way to acknowledge your part in it? Kind of what you talked about as sort of one thing you wanted to acknowledge, kind of using a give to get?
Maybe I could say, like, I'm sorry I've been kind of crabby lately. It's not personal. That's just kind of the way I've been feeling.
How did that feel for you saying that?
I guess that felt okay.
It did? Okay. And how do you think he might respond to that?
Well, I hope he doesn't say, yeah, you have been crabby lately.
Okay, so that's a positive. So is there a way for you to say what you just said and kind of let it be known that what kind of reaction you're looking for? I don't have a great answer here. I'm just trying to think about it.
Maybe I could just say, but I'm trying really hard, so that I kind of end on a positive note. Like, I know I've been crabby lately. I'm sorry, but I'm really trying hard not to.
I think that sounds good. And it doesn't really give him a chance to respond yet, which might be important. Okay. And so, what do you think he might say if you said, you know, I know I've been crabby, but I'm trying really hard?
He might ask me why I'm so crabby lately.
How might you answer that question?
I could just tell him that I'm struggling with a couple of different things. Like, I could tell him about Eric and how it's been hard for me to be in school without him, and how I haven't really talked to any of my friends because they were all his friends. And that was just putting me in a really bad mood.
Do you think you'd feel, I think if you could say that, that'd be great. I'm concerned that you haven't really talked to him about much that's going on. Does that feel almost like too much? Or would it feel comfortable?
Well, I guess to live here, I can try it.
Okay. So it feels like it might be comfortable. If it doesn't feel comfortable, is there another response you could say to, you know, sort of why have you been feeling that way?
Well, I could just tell him that, you know, I've been coming to therapy, because he knows that I'm coming to therapy. I could say that it's because I'm trying to work out some issues, and I started coming because I was crabby, but it couldn't get any better.
Okay. So maybe not necessarily having to talk about sort of all the issues, but, you know, I'm here in therapy because I'm trying to work on that. So just to sort of reiterate to make sure we're sort of on the same place. Thanking him for coming, you know, saying that you'd like to work on kind of improving your relationship, and that you recognize that you've been crabby, but you're really working hard on trying to fix that. Is that part sounding okay so far?
Yeah.
Okay. So if we think about sort of what our goals were, which ones do we think we need to kind of address next?
Maybe that would be a good time to tell him that sometimes the comments he makes can make me crabby.
Yeah, it seems like a really good time, because I'm a little worried that he'll do what you said before, which is, I know you've been crabby. And so it sounds like it might be safest to get that in sooner rather than later, so that he doesn't say something that quickly gets you sort of off course. So how do you think you can word that in a way that he's likely to hear it best?
That's a tough one. Maybe I could say that if you, that I could tell him, I could give an example from last time, saying that when I tried to say, like, hi, how are you, I felt that you were being sarcastic. And sometimes I do feel like you're being sarcastic to me. And I just would appreciate if you were just straight with me and not sarcastic.
Okay. I think using an example is a great idea.
Mhm.
When he says that, and you feel like he's being sarcastic, can you put a feeling to it, how that makes you feel when he says something that you think is sarcastic?
I guess it makes me feel negative.
Okay. Negative about yourself or about the relationship?
About our relationship. Like, we're not going to be able to connect.
Do you think maybe adding in that piece might be helpful for him to really understand why those comments are so bothersome for you?
Yeah, but I'm worried that he's just going to say, like, oh, I'm just joking. What's the big deal?
Okay, so I think that's a good concern. So first, before we move to that, let's put those two things together, kind of letting him know that they're problematic for you and why, and sort of how it makes you feel. Can you put that together?
So sometimes when you say things like I'm a drama queen, or when you say sarcastic stuff, it makes me feel like we're not connecting. It makes me feel like you don't understand me.
And if he were to say, I'm just joking, what could you say to that?
Well, I guess I could say that, you know, it might be, I could say that nobody's laughing, so it's not a very good joke.
Okay. I can understand sort of why you want to have that reaction, and it sounds like that's kind of the reaction you had when you saw him last week. You kind of rolled your eyes and said whatever. But that reaction doesn't seem to communicate to him exactly what's going on for you. So how else might you respond? I mean, I think you're right to be upset and to let him know that you don't think it's funny. Can you do that more clearly?
Maybe I could just say that, like, well, I don't think some of those jokes are funny because I'm going through a hard time, and just being crabby is not, you know, it's a bigger deal than just having like one day being crabby. It's been like this for a couple months now for me.
So it doesn't really feel like a laughing matter to you.
Right. It's kind of more serious.
Okay. And if you were able to express that to him, do you have any sense of how that would feel for you?
Well, I guess if he hasn't realized it, maybe he'll realize that it's a bigger deal.
Okay.
That it's not funny to joke about my mood.
And I wonder if there's another piece you could add there, which is not only do I not think it's funny, but in fact, it makes me more angry and more irritable, and I don't want to be around you. I mean, maybe he doesn't understand the consequence. It's not just sort of how it makes you feel, but if his goal is to sort of spend time with you and your goal is him doing those things, make that less likely to happen. Do you think adding in that piece might be helpful?
Yeah. I could say that when you make a comment like that to me, makes my mood worse. It makes me really annoyed at you, and it makes me feel like we're not going to be able to, you know, have a good time together.
Okay. I think you're doing a really good job. I feel like we've talked about so much, and I know we haven't gotten to this idea yet of spending more time together. But I'm wondering if it may be helpful to sort of practice what we've done so far, just because I don't want to get ahead of ourselves too much. Is that something that you feel like we could do? Okay.
I just want to point out that
Okay, so then they go into an actual just discussion of what they've talked through. And I wanted to bring up the slide of communication skills. Next. So this is a list of 7 communication skills that I was trained with Marion during the groups that we were doing for interpersonal therapy to prevent excess weight gain among adolescent girls who had high BMIs and experienced loss of control eating. So this is a little bit further on, and we're going to come back to it. The slide is in there. It's just a little bit later on when we talk about IPT-WG. But I wanted to go to it now because it seems like a relevant time to talk about the communication skills that you saw Jamie using. So this slide is in your handout. It's just later on in the handout, and we're going to revisit it in a few minutes. So, or later this afternoon. So these are the skills. Remember I said yesterday that there are skills that I've used in my real life? Here they are. I really think this way now. So when I'm communicating with someone, I try really hard to follow this little template in my head. I encourage you all to basically memorize it because it will help you. So the first is strike while the iron is cold. And so this was used primarily with adolescents. I have to tell you, I use it with adults all the time. And I might frame the words a little bit differently, but not always. I mean, it's very appropriate. So strike while the iron is cold is essentially means pick a good time to have a conversation. So the idea of, addressing your parent right when he or she walks in the front door, tired and just getting home from traffic and everything is probably not the best time to have a conversation. Talking with your spouse about finances at 11 p.m. on Tuesday night, probably not the best time. But if you're a working parent, that may be the only time you feel like you have. So you have to really sort of be flexible and understand that the patient is probably doing the best he or she can to use these communication tools without knowing it, right? But we really just sort of emphasize that in order to be more likely to get a conversation going that feels good to you, you've got to pick the right time to do it. And sometimes when I talk about this, I think patients get a little overwhelmed by the idea of setting like a family meeting or making too big of a deal about it. And I say, look, this is all going on in your head for the most part, right? So if you're thinking about what is, and I would talk to a patient like, okay, so say you want to have a conversation with your husband. What are times of the day or week that he's usually in a calm state of mind? Maybe it's Saturday morning. Maybe it is Wednesday nights if you know that the family doesn't get started until later on Thursdays. Whatever it is, like whatever works in your life. But you don't have to necessarily set a time, although some people like to do that. So on the other end, some people will say, it works better for me if I say, on Saturday morning I'd like to have a few minutes to talk to you, because otherwise we don't have time to do that. So sort of know your patient, role play or problem solve ideas with them about what is an actually decent time. Can't be perfect, there's never going to be a perfect time. So the next is use I feel statements. I don't know if you heard in there, but the patient said, I feel like you're being sarcastic or something. And I always joke and I say, I feel like you're a jerk is not an I feel statement. And I even say that to adults because you'd be surprised when you ask patients to say an I feel statement, they say, I feel like my husband's a jerk. Or I feel like he doesn't understand me. And so I always say, I feel must be followed by an actual feeling word. And maybe it's I feel misunderstood, maybe it's I don't feel heard, things like that, but the default is I feel that you. So be on alert for that, listen for that, and then I joke with patients all the time about that. I'll say, I feel like you're a jerk is not an I feel statement, and they usually laugh. So, and then be specific. So when you're approaching your husband, let's say it's this patient who wants to talk to her husband about finances, she can't say something and expect a positive response if she says, I feel like you're an irresponsible jerk about finances and we're going to go into bankruptcy. That is not an effective communication strategy, but it's a sentence that is common among argumentative couples. So we might talk about a time when you could have that conversation when you would say, I feel scared about our financial future, and I worry that you and I are not on the same page about how we spend our money. Just that change, communicating the very same thing, totally changes the dynamic of the conversation. And so being specific next is there are some particular things on how we spend our money that I'd like to address. I think we spend too much money on, eating out, and our cable bill is twice what I think it could be if we bargained with the cable company. So really specific ideas that you can communicate to the other person about things they can do. So you heard it in that role play where she was talking about what could dad do differently, right? So not just I feel like you're a jerk, but I feel more sensitive lately. I've been going through a really hard time, and when you make sarcastic comments, that seems to trigger my mood and make me feel worse. So specific examples, you heard Jamie say a specific example is a great idea. For example, when you said, you know, oh, whatever, don't leave your drama queen self at home, my feelings really got hurt. That's a different communication, and it has a specific action. This one's sometimes hard for people because people aren't often used to asking for what they want or need. So that can take some time to sort of get to a specific request that people want. And this is also an opportunity, just anecdotally, where I found, especially with adults, I almost just call them grown-ups because I have a 4-year-old, especially with grown-ups, I find that it's an opportunity where suddenly you notice if their expectations of the relationship might not be realistic. So if they get specific with something like, you know, like let's say I'm worried about my husband's health, and what I really want is for him to exercise 6 days a week. Because I exercise 6 days a week, and I think that's the right way to do it. And if we're talking about a husband who has never exercised before, like that's an unrealistic expectation, right? And she is going to be worried sort of indefinitely because that's probably unlikely to happen overnight. So then you sort of have an opportunity to talk about that, back to that role dispute thing about the differing expectations. And until you make someone articulate what their expectation is specifically, sometimes they don't even realize that it's unrealistic. So this is a good opportunity to do some reality testing and some perception testing and determine whether or not that's accurate. Next is put yourself in their shoes. And there should be a parenthesis here that says, and then say it. So it can't be all in your head. It can't be, for example, let's say with a dad. An example of that might be, Dad, I know that when you're saying this, you're really just sort of like joking and trying to, you know, make me laugh. She might be able to think that, but if she doesn't communicate that to her dad, he has no idea that she's trying to put herself in his shoes. So if we go back to the example that I'm creating where the wife wants to talk to the husband about their finances, she and I, in a conversation, she might be able to get to the place where she says, you know, I do know that he's trying. I really do understand that he, you know, either doesn't have a lot of financial training or, you know, he's come from poverty and didn't understand or whatever the circumstances. And she softens a little bit when she says that, like I really can understand where he's coming from, but it just gets me so nervous and I'm so angry and I don't know what to do about it. So when you set her up to have that conversation with him, she's got to communicate what she just said, how I really do understand that you're trying your best. So putting herself in your shoes, in his shoes a little bit, and I just frame it to people as that doesn't mean you have to agree with that person to acknowledge what he or she might be feeling. So if it's about an argument, right, let's say this is the argument about finances has been ongoing for a long time, and the husband isn't actually trying his best, maybe he's sort of a spendthrift or something, or like he's, I don't know, whatever, loose with money or something, she might just be feeling really angry. And he might be feeling really angry. He might be feeling attacked. So in that case, she's going to say, I'm not putting myself in his shoes, like he's the one who's wrong. And it's really important to say, just because you acknowledge how he might be feeling, isn't agreeing with him. So for example, it might be something like, you know, maybe when I say this to you and we've had these discussions over and over, maybe you feel like I'm attacking you about it. That's just putting yourself in his shoes, even if the wife is saying, I'm not attacking him, I'm trying to save our family's future. Just acknowledging that can, and I say to patients, like it opens the gate. And the harder to communicate the other person is, the harder to communicate with the other person is, the more important this skill is. So the more sort of defensive, angry pushback you have in the other person, the more emphasis you want to put on putting yourself in the other person's shoes.
So this is kind of like a really important meeting, right, for the daughter and the father. And if you have a client who really has really poor communication skills, at what point, because like I'm thinking of like the IPT skills and the interpersonal effective communication, validation, I feel all that stuff. That's really a lot to learn about how to communicate. And so at what point might you sort of interject that psychoeducation in this process? Because like as I'm watching this, I'm thinking this is a fairly articulate young woman. She can communicate skills. I think of some patients that I work with, you know, and they're like, I don't know. Yeah, I don't know. So it's like, I'm wondering at what point do you, without, like it seems like you would have to sort of interrupt the IPT flow of session to sort of bring that communication, psychoeducation to them?
So this is where IPT is flexible. If you have a patient that is really struggling in this area, then you do psychoeducation. I mean, learning how to communicate effectively is in the realm of IPT. So taking time to practice through role play, and P.S., when you're addressing this, you're also modeling effective communication with that person, right? Because being able to say to someone, I think we need to spend some time really building your communication skills. You have to sort of approach it gently, right? Because it's really easy for the person to hear you stink at communicating, right? And so why would you not use these skills, right? I feel a little concerned that and Jamie did a little bit of that, I feel really worried that if we go right now out and have this communication with your dad, that it's not going to go well. So how about if we practice communication skills, so getting specific, right? And I know it might seem like how I'm talking that you don't have any communication skills, but of course that's not true, right? And we're here together to work on building new ways of communicating that might be more effective in helping you get what you want or get, a more peaceful coexistence with this person. So you're sort of using these skills as you do it, and then talking to the patient about the skills. So if we sort of stay with that, right, when you're communicating with them, if you're saying like, I'm really worried that if you go out and do this, like it's gonna fail. What you don't say speaks volumes versus, I'm worried that if you're not gonna get exactly what you want, but I think if we talk about some communication skills, I think that you're gonna be in a much better position to have this conversation. Suddenly you've just changed the whole nature of the conversation just by your body language. Just sort of saying, inviting, you can do this. Like we've got a toolkit here. It's normal to have to use it. Let's teach you how to use it, and then you'll go out and do it. So building confidence by just expressing it. And then, so I think there's a part in there where the patients are like, I don't know how to say that or something. So then it's your job to make a few ideas. So, okay, well, I have a couple ideas. What do you think about this? Or how about this? Or how about that? Do any of those seem reasonable to you? And by that point, I hope you know your patient a little bit, so you have some sense, right? You're not going to say, you're not going to use particularly articulate wording for someone who can't go there. You might sort of simplify the example you give, and vice versa. So that's where your clinical judgment comes in. And then in classic IPT, remember, don't give up. Keep trying. And that's real. So know that your patient isn't going to miraculously be a great communicator. But if the patient has gotten X far in his or her life, communicating as he or she does, then they're doing something, that is working for them to some regard. So I don't assume that they have, very poor communication skills. Sometimes they're not great. I just sort of say, like, let's build a little bit. If we can move them a few inches, they don't have to move a foot to have reciprocal feedback in their relationships, because the people in their lives are used to communicating with them in that sort of poorly communicated way. So put yourself in their shoes and then tell that person, use words to express that. what you don't say speaks volumes. That's the idea of body language. And sometimes, especially with teens, I'll do this. So I'll say, imagine that I walked in, as I'm pretending that you're my client, I'll say, imagine that I walked into session today and I was like, okay, Christy, tell me what you got today. And they usually like laugh, and I'll say, that would be so different than if I walked in and said, okay, so tell me what you got today. Same words, totally different meaning. And particularly teens aren't always aware of what their body language looks like. And now, more recently, I'll say, imagine if I said, okay, tell me what you got today. And I'll model that, right? Because nobody wants to talk to someone who's on their phone. And teens really need a reminder if you're going to talk to someone. By the way, adults do too. To put their phones away. You would be amazed how many people come into therapy session holding a telephone. Does that happen to anybody else?
Yeah.
What do you do? What do you do?
I have parents do it. So they'll come in with their kid, and the kid will sit down, and the parents will be playing a game on the phone. And I just, sometimes I don't even know what to say.
So what should we say?
I usually,
Speak up, please.
I usually say, we've only got so much time, and I want you to be able to get the full benefit out of it. So if your attention is split between your phone and the session, then you're not going to get, what you need.
Yeah.
Do I tell you that you multitask really well?
Yeah.
Oh, yes, now we have.
Maybe we should role play this one, huh? Actually, yeah.
Yeah, I mean, sometimes I use the phone, the activity to engage with the kids.
Ah.
I work with kids mostly. Sometimes I have kids that are very hyperactive and they work better by doing two things
Two
at the
things,
same
yeah.
time. So I allow them to keep the phone and talk to them at the
Yeah.
same time.
Yeah.
So it depends on the needs of the client.
Yes, I think that's right. I do, I think you're right, it does depend, and I think that these skills could actually even help you in that circumstance, right? Yeah.
I have as part of my intelligence at high school, as part of it is when we're here, we're going to be doing work. And if we're here for a long time, or say you just need a safe place to go, and we need that focus time, you can be on your phone because it's just you need to calm down and regulate. But I put the phones in a basket and then we grab a fidget or toy, so like we trade them out.
Yeah. Yeah.
Just something else they can have.
Yeah. Has anyone been bold enough to pull out your own phone and look down and just see how long it takes? I've so thought of doing that. I thought of, I'll just reach over and just sit here next to him. I can look at my phone too. I wonder how long it would take a parent, right? To look up and be like, what are you doing? What are you doing? I really have. I haven't been bold enough to do that. Maybe someday. So what you don't say speaks volumes. I do talk to parents about that also, especially when they're talking to spouse. A lot of times, sort of people, even in session, you probably see this, right? When people start talking this, where they take the pillow off the couch and put it in front of them. A lot of like covering up, folding up, this sort of thing. Yeah. So just pay attention to that, and even in session, it's okay if you're comfortable with a relationship to talk to the patient about what that body language might be communicating to you. Communicating nerves, communicating anger, and it's okay to draw awareness to that. Have a few solutions in mind. So if we go back to the wife who wants her husband to exercise 6 days a week and you draw that out, so that's probably not a realistic goal, but if what she wants to talk to her husband about is her concern about his health, then have a few solutions in mind. So, you know, I thought maybe we could go for a walk together once in a while, or I thought maybe we could do some meal planning together on the weekends, or whatever it is, I don't know. But the patient should go into the conversation not aiming for just one outcome, because then it's a setup to potentially flop, right? So you want to sort of set the client up to be as likely to walk away feeling good about it as possible. And then the remember, don't give up. This is, I said yesterday, that I sort of never see an end to the possibility of communicating. So in one of the cases we're going to talk about, this case had been in impasse or dormant for a year, this conversation. And patients believe, erroneously in my perspective, that it's too late, that you can't go back. And I just don't think it's that way. I get patients don't want to go back and revisit things, but I really try to remind them that in long-term relationships, whether it's with a parent, a friend, a spouse, a boss, that the relationship evolves over time. And that means you can circle back and talk to the other person about something that happened sometimes years ago. And if you use these skills, it might sound something like, I've been thinking about this more and more, and it's just been sort of making me really anxious. And I know this might seem like it's coming out of left field to you, because we haven't talked about it in a year, and I imagine that you're a little worried about what I might be saying. So you're using the skills as you bring up an old conversation. An alternative way of seeing the remember, don't give up is if a patient, if you role play and you set it all up and then they go out in the real world and they have the conversation and they come back and say, well, that went south and it was terrible, let's try again. Let's try again. And sort of normalize. You've been communicating this way to this person for this long. It's sort of expected to have some bumps in the road as you keep doing this. So that's okay. Let's just try again. So we wouldn't say like, oh, that's too bad. Oh well, of course, right? You would really encourage them to keep going. So that's the communication skills. And again, as we talk about IPTWG, we will go through those, but I thought, given what we had just seen, it was probably an appropriate time to move on. Okay, so we just did the role play example for the intermediate phase. So your tools for the termination phase are to review the progress in treatment and identify warning signs for relapse once treatment ends. So be really explicit with your patient about what do you see coming down the pike that you think might influence your ability to, keep your binge eating reduced or lower or something. What's coming? Like, are the holidays coming? Whatever. Outline goals for the remaining work in the session. So whether you have 3 sessions left or 6 sessions left, talk to the patient like, okay, we've come this far. What should we use our next X number of sessions to be working on? So you sort of set up a little bit of a template. Given that it's our last 4 sessions, how should we use that time most effectively? Discuss areas with the patient for which additional work may be beneficial. So you don't have to leave it all up to the patient. If you see, for example, that you've been doing communication and they just sort of aren't getting it, you could even say, okay, in the final 4 sessions, let's really keep digging into these communication skills. Let's keep practicing. Let's keep reviewing it and role-playing together. So you could be reinforcing it all along the way. And then collaboratively talk about how the patient could continue to use the skills that you're working on after treatment ends. So again, reinforcing the idea that just because the acute phase of treatment I don't think that's me.
Yeah.
Sorry. So reinforcing the idea that there's still responsibility of that patient to continue the work after treatment ends. That treatment end isn't the end of their work. And then plan for the post-treatment work. So what does it actually look like? Are they going to do maintenance treatment with you? Are they going to join a group? Are they going to do CBT? Are they going to check back in 6 months from now and just sort of see how they're doing? Whatever it is. Making ensure that you develop goals that the patient can realistically work on for themselves. And I say that, I'd rather set you up to feel successful by identifying realistic goals that you can work on than to set up really lofty goals that you're going to sort of struggle with and then feel disappointed and discouraged. So here is a little brief, maybe 5-minute or 7-minute role play for what it looks like in the termination phase. And after we do this and review the maintenance phase, then we're going to get into some cases. Okay. Sorry, it's 10 minutes.
Are you?
Good.
Good. It's good to see you. Yeah. Again, your binge record this week is the last week as was like kind of squeaky clean. So how's it been feeling? Oh, sure.
I'm pausing because, so he said binge records. So what he does is just essentially give the people a questionnaire at the very beginning that asks about the number of times they binged during the past week. You can certainly do that. In the manual, you'll see there's no actual discussion about using that, but it's certainly an appropriate thing if you want to do it, or you could just ask a patient to self-report. People have a good sense of how many times they're binging. Yeah.
Do you know if he just created his own questionnaire, or he's using anything standardized?
He might be using the binge eating questionnaire or the binge eating scale, but I don't know exactly for this one, but you certainly could do it that way. Depending on the patient you're working with, personally, I find that just a discussion is really effective. Or if you're more oriented in data, which is helpful too. And by the way, I keep track. So if the patient talks to me about it, I make notes so that I can reflect back in my notes later and say, when we first met, you talked about binging every day that week. And now you talked about only binging once. So I sort of, use my own data, but you could also just have them write it down. Sometimes I'll have patients, it depends on the patient, but sometimes I'll have them do like a check mark in their calendar on a day they binged. And then, so it can be as simple as something like that.
It really does. Yeah, it's been really a process, so that's fantastic. Tell me about what's been going on this week.
I had a good conversation with my mom.
Oh, nice.
Yes, so it feels good.
Tell me about it.
So I just talked with her on the phone, and yeah, it just went really well. We actually, after that, we had a Skype meeting. We had a Skype meeting last night, I guess it was. And yeah, caught up a little bit and
Nice.
kind of talked about some things.
Great.
Yeah.
Oh, nice, nice. Happy to hear about that. And then, I don't remember, I'm trying to think from last time, any Alan updates or,
Still seeing it.
Oh, nice, nice. Things going okay? Good. Well, I'm happy to hear that. And then, I guess the other thing that I wanted to, talk to you about, I know we, kind of, I mentioned it briefly, but today kind of marks the kind of beginning of that kind of final phase for us. So then over the next, 3 sessions, we're going to be starting to kind of wrap up our work together. And yeah, I've been feeling that way too, because it's hard to want to bring that up, because it's been really just great working with you. And so I really don't want to see that come to an end. But I thought one of the things that's really important is maybe just to get us starting to talk about, and again, we don't have to do it all today, but just at least get us starting to talk about, some of the changes that you've made, things that have gone really well for you, and really maybe kind of recap how it is that you've gone from almost binging daily to almost now you're not at all, and kind of maybe we can kind of talk about how that's gone. Because I think the other thing that's really important is not only the things that you've done in terms of how things have gotten better for you, but I also want us to start thinking about too, okay, what's going to happen when we kind of get to the end of our work together and beyond. So in terms of how you'll kind of keep the work going, so. I kind of thought, I didn't I feel like I'm kind of being like a wet blanket here. You've had a really great week, and now I'm bringing up, our kind of departure. But I think it's really important to kind of mark that transition, and also to mark it too by having, things go so well. I think it's really important. So, and I guess the first thing I want to talk about is, I guess I'm pointing my pad of paper because it's like it's so filled with just all the different things that have occurred for you, over the last several weeks. And I think the first thing that's really notable to me is I really appreciated your willingness to engage your mom, because I know that that's been so hard for you, and it's been so painful, the way that she's treated you in the past. But that, I guess I'm even getting kind of emotional talking about it, because it's just been so rich, the transition you've made in terms of the way you've engaged her in a more genuine way and allowed her kind of back into your life. And it seems like that's been, really vital to your, like getting better. Yeah. Mm-hmm. So what's, in terms of like from your perspective, kind of what's that been like for you, kind of emotionally?
And it feels good. It's nice not butting heads with her, because
Yeah, sure.
I mean, I want a good relationship with my mom. I don't choose purposefully to not have a good relationship with her.
Right.
Yeah, it feels really good.
Nice.
And I feel like I can have better relationships other places as well now, because that's healthy.
Right. Well, and also to go along with that is that kind of the strategies I think that you've, my hunch would be is that some of the strategies that you've used to engage your mom in a more meaningful way have really kind of come in handy in some respects in terms of like some of the other relationships that you've had, especially I know that you and Kathy have gotten a lot closer, and even the fact that you've allowed yourself to kind of, connect with somebody else, like, with Alan, and, I know you were talking to me the other day about some other friends that you've, met and people that you've really gotten a little bit closer to, so that's been really exciting. Yeah.
Feels good to not go home and
Right.
feel terrible.
Right. Yeah. So then, kind of from your perspective, again, we'll talk more about this. As I realize I'm kind of putting you on the spot, but as you kind of have thought about it or thinking about it, and maybe you can think about it too, even from now into the next couple of sessions, but just trying to think about like, what is it that you've really done that you really feel like that's really helped you make changes in the way in which you've, managed your food or your binge eating?
Just really trying to be more positive within my relationships and being more open and communicating, not keeping things in. So I feel like when I kept things in, it kind of boiled up, and that's what made me want to use something that made me feel better. And something bothers me to immediately express it instead of holding it.
Right. I've noticed that as well. It seems like that's been one of the important things that you've done. It's really helped, with the changes that you've made. What else feels like that? Obviously that's been really important. But what are the other things that you've noticed in terms of how it's been going?
I feel better with myself, and not having comments from my mom anymore, and having a guy in my life who really likes how I look, and feeling happier with myself. Grades are good.
Yeah, things we're really in a good space. And I think the other thing too I was aware of that that you had mentioned to me in particular last time was that, and I didn't get a chance really to talk with you as much about it because I think we had so much to talk about last session, but I was really struck by the fact that you, it seems like you haven't been as body conscious as you have been in the past, and I didn't know if you've noticed that.
Yeah, no, I feel like I've a little bit noticed it. Yeah, especially that you bring it up. Yeah. It's true.
Right. Yeah. Because I know initially, and even there have been times even along the way when you'll make I didn't feel like it looked very good, or I felt like something felt really tight on me, or I just felt like that other people were looking at me and maybe judging me. But it seems like that as we've kind of moved along, that I've really noticed a real kind of a little bit of a shift in the way in which you've kind of been regarding yourself. And it seems like it's been a little bit different.
And not hearing any comments at all from my mom feel like I've gotten to the point where I'm not concerned like that I'm gonna hear a comment either.
Right. Yeah. Okay, so I'm going to go ahead and make you talk about it anyway, but what did you do in order to be able to get those comments to stop? Because obviously I think you did something really significant with her.
Yes. I mean, I thought about what you said about really acknowledging that put a lot of pain on me and stress and weight. And yeah, no, I was able to let her know that. And it's hard. I was scared to tell her that, but I mean, she recognized that.
Yeah.
Yeah, she kind of explained how she thought that she was helping me, or she wanted me to have a lot of friends in high school, and that's what she, I mean, she kind of said like her mom said the same thing to her. And,
Yeah. Well, and that's really not uncommon when you have, it's funny that just even like, like the big research head, but it seems like that it's pretty consistent that, kind of like, mothers to daughters who become mothers to daughters, like sometimes it's kind of what we call this intergenerational transmission of like, kind of criticality about, shape and weight, and so I'm, really proud of you that you, kind of had the courage to address it with her directly and just let her know how you feel. Because, I think, as a parent, I know that you always like, I always want to try to do the right thing, and I always, I don't purposely want to try to, inflict pain on my children, even though my daughters would suggest that I probably do. But in general, I know that's not my goal, is to be, harsh and critical. In fact, I really always, try to really be helpful. And I think most parents try to do the right thing, and I think maybe your mom just didn't realize the degree to which that really bothered you and how much that hurt. And in many respects, how much that kind of really drove you to, really, take it out on yourself, so to speak. And so for you to have the courage to bring that up, I think was really helpful. So I really think that made a lot of differences, as well as, kind of reaching out to others, and again, then just the open expression of your feelings. So, I think the things that we're doing like now, I think I'd really like to see us kind of continue to, obviously you still are doing a lot of really good work in terms of like the things that you're talking about, but yet I'm also aware that, as we're over the next couple sessions, we can kind of keep doing a few of these things, kind of wrapping up, and then our last session we can more or less kind of formally, say goodbye and talk about kind of like what the next steps are, and, some things that you might want to be paying attention to, or things you might want to, be mindful of, but we'll get there. So, yeah, great.
This might be really nitpicky, but when you're in this phase, right, I noticed that he said something to the lines of like, I'm really proud of you. So in my experience, I try to say, you should be really proud of yourself. I mean, does that make a difference? I mean,
It depends on your clinical style. I think in that dynamic, he's sort of owning the parent role, right? I mean, he's saying as a parent, so he's using a bit of who he is in that session, and I'm sure that's related to why he chose to say it that way. If it's a peer-to-peer thing, like, if you're working with someone close to your age, that might feel more patronizing, actually. So, boy, I hope you're feeling really proud of yourself, or something might be a more appropriate way. So I think it depends on your clinical style and the type of patient you're in.
I have two questions
Yep.
for you. The first one is, since this therapy in one way focus on interpersonal relationship, based on the story of this girl, something came to me. How the role, of the therapy involved the issue of forgiveness.
Forgiveness?
Yeah,
Okay.
because I think sometimes it's a very important role in an important issue in relationship. And we use anything to help the person to get to that level before maybe even start thinking about going back or focus on change the relationship.
Not in manualized IPT. Again, if it's your clinical style and you have a case in front of you that seems like it reeks of needing to go there first, then I wouldn't say go there first. And you know your patient and your own clinical style better than the manual does. So I would say use you.
Okay. And the second question is the role of disclosure, personal disclosure as a therapy. So there, and I know certain therapies don't foster that process. And how is it in this particular case?
So, it's a great question. I have to say, I'll just speak from my experience anecdotally using this. With some patients, it feels very appropriate to use a little bit of self-disclosure. And with others, none. And I don't really have an answer about why that is. Probably just your clinical gut would give you some information on that. I do not talk about, and I don't think it's really appropriate, although, I mean, I don't know, someone could always argue the other direction, but if you have a history of eating disorder yourself, I probably would not talk about that. There are models where people in recovery of eating disorders treat people, and I understand that. From an IPT perspective, because we're not really talking about eating disorders, right? The eating behavior, we're talking about relationships. So my disclosure is probably more like, you know, I might, and it's usually some like distant thing, I might say something like, oh, you know, in arguments with a person, I've really had to use these skills myself sometimes, or something like that, because you're talking about the relationship. In the treatment of bulimia nervosa and certainly binge eating disorder, there tends to be, at least in my practice, there's sort of a cohort of clients. I have a lot of men, and I also have a lot of single women. And so I'm really careful about, I don't disclose the fact that I wear a wedding ring, which is more than some therapists do, but I don't talk about my family or my relationship at all, because it's just, you know, if the person wants that and I have it, then it just brings up a whole other thing. So I just tend to sort of steer clear. If someone directly asks me, because people do that, sometimes I deflect like a good therapist, right? I wonder why that's important to you. And other times, I'll just answer. So sort of depends. Yeah.
Part in this model that continues to trouble me is the lack of context given particularly to ethnicity and racial diversity, because you know, if we're talking about interpersonal, we may be talking about intercultural, but we may not, and that can make a huge difference. And then in terms of the styles of communication, huge. So, and it seems to be like a little add-on. Oh, it's a biopsychosocial. But it's big. It's like overarching. It's everything.
So do you have an example of what you're thinking?
Communication styles. So, you know, the difference, say, in an African American family to, I don't know, a Chinese family. Like, markedly different. And then also, I mean, how do people relate to each other, and what are the expectations of relationship?
So IPT has been shown to be actually, in some ways, in some studies, more effective among African American communities. And so in research trials, African American participants using IPT for eating disorders like binge eating disorder have shown to improve even more than Caucasian participants. I don't know particular studies on Asian Americans, but I can say I've treated people from Asian cultures where communication is not encouraged between parent and child in nearly the same way, and where hierarchy is much more important. And I think that's not specific to IPT. I think that's specific across every clinical intervention, that you do have to get to know the patient and the surrounding culture in that patient to use any of the skills. And again, this is, so if it was the case where an Asian family and the let's say the daughter was just saying like I'm not talking to my parents, like that's not okay, then it's not our job to say you must talk to your father. it's more our job to say, what then do you need, given your culture, like given the, you know, the dynamics that are accepted in your family, what do you need to do to get the support you need? And does that look like talking to a friend about it? And then you would role play there. So it's not our job to force communication where communication isn't welcome. It is our job to help the patient understand, given the realities of my life, what are my options? So, and that to me feels true when I'm using CBT. In graduate school, most of my training was in community-based churches, African-American churches in the Washington, D.C. metro region. So I've done a lot of different work among African-American populations, and yeah, there's some differences and there's lots of similarities too, and it's really just about the particular patient in my experience.
Oh, no, it's just, it absolutely cannot possibly be about the individual.
In IPT, the work you're doing is about the individual and their interpersonal relationships, which is part of their culture, of course.
But, and so that's why I'm sorry, I don't
No,
want to
please,
go
please.
back and forth. But I just, if you're having like if there's a cross-cultural interpersonal relationship, it's just not possible to say this is about the individual. This is about an individual relationship because it's so not.
Give me an example of what?
Well, just so take the African American stuff that we're talking about. That the power of language that's very specific. So you can't, you know, you have this history that is very alive for the African American community. As I understand, I'm a foreigner, so you know, and so the language that is used in the therapy room and then outside of the therapy room is potent. And every interaction that person has that's cross-cultural builds and so it becomes this whole experience of life. And I really don't think that this model embraces that. I mean, I hear what you're saying, and I hear that, you know, it's been successful in African American communities, but it isn't evident here in the world. So I mean, I don't know that I would know how to work with that.
In working with an African American client, for example? Does anybody have any thoughts about that? Yeah.
Well, you kind of brought it up yesterday a little bit about sometimes it's the way you phrase things. So whether it's being more direct or more indirect or more gentle than more confrontational or direct or just direct, I think that makes a difference.
I was also thinking, you're not really telling them what to say. They're coming up with it. So regardless of what culture they come from, they're coming up with what they think is going to work in that interaction.
Absolutely. That's, I mean, Jamie Young does not say the word like rapping or whatever she said, right? That's her client's words.
Right. It's all
And
coming
so
from
she's
that
reflecting
client.
what
Right.
the client is saying.
I'm thinking of a young woman that I'm working with right now who's second generation Liberian. So her parents came here amidst the war, and she really is struggling significantly with her relationship with them because their experience growing up is so very different than hers has been. And so part of what you had just said before we stopped for questions was kind of around what are the real opportunities here? There are things that are not going to change. And what are your goals for the relationship? And how can we modify things to get there? And that's where I can see this being really effective because she, you know, is grieving in some ways a loss of a relationship that she sees some of her peers have that she feels like I'm not going to have that because that's just not the way my family works. And yet they're my family and I love them. So how can I have some kind of a connection with them?
Other thoughts? You had something?
I mean, I was thinking, two things. One is that it's true that the culture bring a huge difference in the way we communicate and our perception and expectations around the world. And that can influence the way we communicate with our parents or with everyone. I mean, a couple of days ago, we were discussing in our staff meeting about sometimes how we interact. I work mostly with Latino families because I came from that culture, but even inside of what is Latin America, where there are so many countries, don't have expertise in all the cultures, and even I cannot have any expertise in my own because the people even come from the same culture, they can behave and perceive the world in different ways because of their own experiences. So we need to be very careful about also creating stereotypes in our mind and try to apply the same formula to everyone. So the thing is how we can, in one way, take in consideration that, but based on what is important for the client, remove our stereotypical things about what is important for the client and try to work with them. Because I said, I came from people think that Latinos like to touch each other. Somebody come and touch to me and I'm gonna probably punch them in the face because I don't like it. So, how we can integrate their needs and their perception in the work that we do with them.
And I think it's, you keep emphasizing that this is a collaborative model, that when you're working with a patient, that you're really coming up with the goals and expectations with them. So I think that then can acknowledge that part of that exploration at the beginning, as you're formulating these things, has got to include what their values are, what the culture is. And what's also so important is, what you were talking about is, it's not just the culture that family comes from or the place they come from, but it's what is the culture within that family and what are their values. And so that's what the individual is bringing, and that it seems to me in this model we need to hear from the client what that means to them as we're working with them to define what some of these role plays would be like.
Absolutely. Absolutely.
Interesting and useful comments. Totally unconvinced.
Totally unconvinced.
Yeah. I don't think it fits to it at all, but good comments. Yeah.
We're allowed to disagree. Yeah. Okay. So, maintenance phase. So the tools for maintenance are, remember that the goals for, and this has been studied mostly in IPT for depression, and I studied it and have manual information on it. So it's to maintain a client's sense of competence and to continue to help the client continue to get their interpersonal needs met outside of the therapy session. So once the acute therapy has ended, making sure that they know that there's still work to be done on their part in ongoing maintenance. We do a lot of relapse prevention and expectation setting. And again, I mentioned yesterday that I term it as relapse planning, not relapse prevention. That's just my personal take on it. You could say whatever you want. And it's important that there's an explicit discussion that determines how this maintenance plan is going to work for the two of you. So as a very brief review, the problem areas that we then dug into yesterday at length were the role disputes. So lacking these reciprocal relationships about the role in a relationship, and is often reflected in some conflict. The interpersonal deficits, when a patient has an apparent sort of lacking of close relationships, maybe social withdrawal, and probably has some difficulties with communication skills, maybe some social anxiety. Interpersonal role transitions, so the struggle adjusting to a change in life that requires a new or a different role. And these are very common to occur along normal developmental trajectories. And then grief, so grieving the loss of a significant other or person or relationship in your life, and whether that's related to death or loss of a relationship through divorce or moving or whatever. And then life goals, feeling at sea with your life goals and plans. That's Rebecca Murphy's suggestion, although not in the IPT EP manual. Okay, so some cases. Hooray, we made it. Okay. Do you guys want to take a break? Yeah, let's take until 10:15 or so, like 10 minutes, okay.